Welcome. My name is Divine. I am a fourth year medical student. You're welcome to our 17th episode of the Divine Intervention podcasts. And in today's episode, I'm going to be discussing a series of diseases that are super high yield for step 1, for step 2 CK, most likely for step 3, and also for the pediatric shelf. And the topic today are the diseases of the pediatric population. This will be the first part. I will talk about other diseases in later podcasts. So let's go ahead and get started. So the first question says, a 7-year-old Asian male with chronic watery diarrhea and bloating. Stool is positive for reducing sugars. A hydrogen breath test is positive. So what's the diagnosis and how is this treated? So, if you notice, I mentioned an Asian in this question. That's the first thing I mentioned. And then I mentioned having like diarrhea and bloating, okay? And you see reducing sugars in the stool. Hopefully this should get you thinking about lactose intolerance, okay? So the pathophysiology here involves a lactase deficiency. Remember, lactase is a brush border enzyme. It's a kind of disaccharide, if you may, okay? Because on these board exams, you may not see them refer to the deficiency as a lactase deficiency. They may write disaccharide enzyme deficiency or brush border enzyme deficiency. So watch out for that, okay? And one of the ways you can diagnose this is to do a hydrogen breath test. It's usually positive because the acidity, the lactic acid that's hanging around in your GI tract, right? It can be reflected in your breath, so it can be detected in that way. Another thing to do is you can also just check the stool, look for reducing sugars, although that's probably a less sensitive test, or I guess a less specific test. Now, how do you treat this? You treat this by basically avoiding things that contain lactose. Okay, so like dairy products. You could also give lactase supplements. Although, if it's an infant, and let's assume the infant is you need to breastfeed or formula feed this infant. One innocuous answer on the exam may actually be to go ahead and give soy-based formula. Okay, so just watch out for that. So let's go on to the next question. Now, 23-month-old is brought to the pediatrician by his mom. Physical exam is notable for pronounced bowing in the lower extremities. MCV is 60, that's low. Serum calcium is 7.1, that's low as well. He has an erythematous blistering rash in front of both patellae. There is diffuse muscle wasting. What's your diagnosis? What's the diagnostic testing? How is this treated? And let's assume this patient has an anaphylactic reaction to blood transfusions. So what are we talking about here? This question looks kind of non-specific, but it's a very classic exam presentation, right? So this kid has a microcytic anemia, so potentially from iron deficiency. This kid has hypocalcemia, that's like low calcium, and the kid has rickets, right? So that tells you this kid has a vitamin D deficiency. And if you're thinking about it, there's also this rash on extensor surfaces of the extremities. Hopefully that should also get you thinking about something else, okay? So this is a malabsorptive problem with a rash. If you see malabsorption plus rash, I really hope you're thinking about celiac disease, okay? So this child does in fact have celiac disease. It causes malabsorption and it causes multiple vitamin deficiencies, right? So like you have like a vitamin D deficiency, a folic acid deficiency, and iron deficiency. That's why the kid has all those problems. The vitamin D deficiency creates the rickets. The iron deficiency creates the microcytic anemia. Okay, and the classic exam presentation is that these kids may have like muscle wasting, they'll have like flat buttocks, they'll have anemia, they'll have rickets, again all from these vitamin deficiencies and the muscle wasting. And the rash that is classically described, hopefully you remember that this is a dermatitis herpetiformis, okay? It's like a herpes-like rash on the extensor surfaces. And really the way you make the diagnosis is you do like a serum study where you try to find IgA against tissue transglutaminase, okay? Although for some reason there's actually a pretty strong association between celiac disease and IgA deficiency. So if a kid is IgA deficient, that IgA against tissue transglutaminase test may be negative, right? So what you could do in that case is to check for IgG antibodies against gliadin, okay? So that's something high yield you want to know. Another thing you may also want to do is you may want to do like a duodenal biopsy. And on that biopsy, the classic exam description of your findings are that you have atrophy of the microvilli, okay, so like villus atrophy, and they will tell you that, oh, there is an increase in the number of lymphocytes between the epithelial cells that line the duodenum. If you see that specific association, basically stop reading the question. The answer to that is celiac disease. And these kids, if they have like IgA deficiency, they don't have IgA as being if they have an IgA deficiency, IgA sort of becomes a foreign particle to them, so they may actually form antibodies against that IgA, and those IgA antibodies can dock on the surface of an eosinophil or a mast cell, and then when they get a blood transfusion that contains IgA, that IgA can bind to that IgA on the surface of a mast cell or eosinophil, cause cross-linking of the constant regions of the IgE, and then you have degranulation of those cells, and then you get into a lot of problems, okay? So those kids can get a type 1 hypersensitivity reaction with blood transfusion, right? So IgA deficiency, anaphylactic reaction to blood products. And really, the way you treat celiac disease is you just avoid gluten in the diet, right? So like foods like wheat or barley or rye, you generally want to avoid those because they contain gluten. Rice does not contain gluten, at least most rice. And you also want to supplement the vitamins that they are missing, right? So like vitamin D to sort of stave off the rickets, or iron to sort of stave off anemia, okay? And this will probably be more of an adult question, but in addition to removing gluten from the diet, you could actually treat dermatitis herpetiformis with dapsone, okay? Remember that dapsone is a dihydrooctanoate synthetase inhibitor. That's one of the steps in the synthesis of folic acid in bacteria. You remember you want to be careful with that drug because it causes a lot of oxidative damage, right? So you want to be careful with that in patients with G6PD deficiency because they cannot make NADPH. Okay, so that's it for that question. So let's go on to the next one. So an 8-month-old that consumes cow milk presents with is broth. Sorry, made a typo there. I'll just correct that right now. Okay, so 8-month-old that consumes cow milk is brought to the pediatrician by his mom after noticing blood in his stool last week. CBC is notable for anemia. What's your diagnosis? What's your treatment? This is more of a question you just want to be able to recognize on an exam. But this is a classic presentation of a milk protein allergy. Okay, basically it's an intolerance to milk proteins. Okay, usually it's IgE mediated, but it could also be mediated by other antibodies. Most kids outgrow this, like after the age of 1, most kids outgrow this. But the treatment is to give them a formula that contains something known as casein hydrolysate. Okay, that's just a buzzword you want to remember for exams. A casein, C-A-S-E-I-N, hydrolysate formula. That was easy. Well, I guess if you could recognize it. Okay, so next question. A 5-year-old kid with chronic constipation immigrated from South America at the age of 1. Ding, ding, ding. A rectal exam is accompanied by an explosive expulsion of poop. A distal colon biopsy reveals an absence of Albach's plexus. What's the diagnosis? There are other patient populations that may have a similar condition, and how is this treated? Okay, how is this treated? So this, hopefully you realize that this is Hirschsprung's disease. Okay, Hirschsprung's disease in general, the pathophysiology, at least for congenital Hirschsprung's disease, is that you have a failure of neural crest cell migration to the distal colon. Okay, alternatively, you could also have like some bug that mediates destruction of your enteric nervous system, right? Like your Albach's plexus, for example. The classic bug here is Trypanosoma cruzi, right? That's why I put that this kid immigrated from South America. So let's assume this kid had Trypanosoma cruzi infection of the GI tract, and they nuked their Albach's plexi, and then basically they have a Hirschsprung's disease. The other patient population that classically has this issue on exams, Down syndrome patients, okay? So remember your trisomy 21. And so T. cruzi will be a cause of acquired Hirschsprung's disease. And basically the way you treat this is you resect the affected bowel, and then you perform some kind of end-to-end anastomosis. In general, you establish the diagnosis with a biopsy, like a punch biopsy of the distal colon. Okay, so next question. 18-month-old with a recent history of an upper respiratory infection is brought to the ED by his mom. He has been having paroxysms of abdominal pain that have made him curl into a ball. Oh no. His mom brings his most recent diapers to the office, with some of them having a red tinge. Okay. A mass is palpated in the right lower quadrant of the abdomen. What's the diagnosis? How is this diagnosis established? How do you treat this, and what's the actual pathophysiology? So this kid, right, so the red tinge, right, so you're hopefully thinking of a red currant jelly stool, okay? This is intussusception, okay? The classic exam presentation or associations are like a palpable mass, usually in the right lower quadrant. They will have like red currant jelly stools because their bowel is becoming necrotic, and they will also have abdominal pain. And just as a quick aside, what is the bug that is associated with red currant jelly sputum? Are you saying Klebsiella pneumoniae, alcoholic? Well, I hope you're saying that. That's a very high yield microassociation you want to know for your board exams. Now, the pathophysiology of intussusception is basically you have the telescoping of one piece of bowel into another. And that telescoping can basically drag blood vessels of the GI tract alongside and can occlude them, sort of like a pressure occlusion, if you may. And that pressure occlusion can cause ischemia and necrosis of the bowel if it's not corrected quickly. And usually the thing that causes that telescoping is there is a lead point that begins the whole process. That lead point for the telescoping could be like a Meckel's diverticulum. I'll talk about that in a later podcast. It could be a hyperplasia of the Peyer's patches. Remember, that's found in the ileum, okay, in the terminal ileum. So that's one thing you want to think about. And in general, the diagnosis is usually pretty obvious, but if you want to do some kind of imaging, you can get an ultrasound, and classically on ultrasound, you'll see like a donut shape. Occasionally they call it the target sign, okay? So if you see an exam question, donut shape on ultrasound or target sign, think of intussusception. Another thing you would actually use for diagnosis, which is also therapeutic, is an air enema, right? So you basically like use a hydraulic force to sort of reduce the intussusception. And it probably reduces the intussusception in like 75% of cases. If that doesn't work, obviously you go to surgery. And just as a quick addendum, what should you think about if this kid, after an air enema, becomes like septic, has like constant severe abdominal pain? I really hope you're thinking of an abdominal perforation, right? Because again, if you're blowing gas into a hollow viscus, imagine you could potentially perforate that viscus and you can get into a lot of trouble, right? In general, for that, you probably want to do like an abdominal x-ray. You'll see free air under the diaphragm, right? That's like the classic thing you see. And basically for that, you need to give that kid broad spectrum antibiotics and just ship them to the OR because he has a pretty high mortality rate. Okay, so next question. So 4-year-old presents with severe generalized abdominal pain, nausea, and vomiting that started 12 hours ago. CBC is notable for a white count of 13,000, which is high. Ultrasound reveals an echogenic material in the right lower quadrant with what appears to be fat stranded. So right lower quadrant, fat stranded. So what's your diagnosis? How is this treated? And what are the potential complications? Okay, so this is I kind of wrote this question to sort of throw you off a little, but this is actually appendicitis. We're used to the periumbilical pain radiating to 2/3 the distance between the umbilicus and the anterior superior iliac spine, right? That's the classic appendicitis presentation in adults. But actually in the pediatric population, appendicitis tends to present as just generalized abdominal pain. Okay, so just something to watch out for. That's why I added some extra for you with regards to the ultrasound findings. Okay, and that sort of leads into the point that in general, the imaging test of choice for appendicitis in the pediatric population is an ultrasound, because you want to shield the kids from the radiation that accompanies a CT scan, which is classically done in adults. Okay. Basically, the echogenic material that we saw on ultrasound in this question was probably like ficalith that obstructed the appendix, caused inflammation, and then the kid had this problem. And in general, the way you treat this is you just hydrate the kid, give them broad spectrum antibiotics that covers your GI flora, like ciprofloxacin, which is a fluoroquinolone, and metronidazole, or a combination of ampicillin, gentamicin, and remember gentamicin is an aminoglycoside and metronidazole. Okay, and then you send them to the OR for lap chole, right? Laparoscopic cholecystectomy. And certain complications that could arise, especially in the pediatric population, is you could form an abscess, okay, or the appendix could actually perforate, and those are obviously worse conditions than garden variety appendicitis. And yeah, so I think I've talked about all I want to talk about with this question. So let's jump to the next one. Okay, now the classically tested genetic principle. Okay, this question is extremely high yield for step 1. So basically, I'm just supplying the names of certain disorders, and then you tell me the genetic principle that's classically tested on exams. Okay, so the first group, we have a myotonic dystrophy and Fragile X syndrome. Myotonic dystrophy and Fragile X syndrome. Hopefully you know these to be trinucleotide repeat disorders. Okay. And I will talk about some of them in this podcast and in a later podcast. But remember that in Fragile X syndrome, you have the CGG repeats. It's an X-linked disorder. And for myotonic dystrophy, you have the CTG repeats. Okay. Now, next group, Engelmann syndrome, Prader-Willi syndrome, and Beckwith-Witherman syndrome. Okay. The key concepts that are tested for those are genomic imprinting with chromosomal deletions. And then the second concept is uniparental dysomy. I'll talk about these concepts later, but as a preview of coming attractions, remember that genomic imprinting just means that one of your chromosomes, either from mom or dad, is silenced. Okay, we'll talk about the pathophysiology behind Prader-Willi and Engelmann in a later slide. But for uniparental dysomy, it just means that you're inheriting 2 copies of a gene from the same parent. Okay, so it's like you're inheriting like both maternal chromosome 15s or both paternal chromosome 15s instead of inheriting a paternal chromosome 15 and a maternal chromosome 15. We'll talk about the implications of this in a bit. Okay, now next one is trisomy 21, right? So that's Down syndrome. So this classically arises from one of two things on exams, right? So it could be from a translocation. Usually it's an unbalanced Robertsonian translocation. I'll talk about that later. It could also arise from maternal non-disjunction, okay? Maternal non-disjunction. Remember, maternal non-disjunction occurs when the homologous chromosomes do not separate in meiosis 1, or where the sister chromatids do not separate in meiosis 2, or where the sister chromatids do not separate in mitosis. Okay, those are all pathophysiological mechanisms behind maternal non-disjunction, and that can present with Down syndrome. Okay, I'll talk about Down syndrome shortly. Now, next part says mom passing the disease to all her kids. So mom passing a disease to all her kids. Hopefully you're thinking of some kind of mitochondrial disorder. Okay, mitochondrial disorders, they're usually like super weird. They tend to have like super weird names like Miller syndrome. I think Miller syndrome is like mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes. There's one called MERF, like MERRF. There's one called Lee syndrome, LEIGH. But I would just say that one big thing, in fact, there's another one actually that shows up on exams every now and then. It's like LHON. It's like Leber hereditary optic neuropathy. The big thing you want to remember with these mitochondrial disorders is that mom passes it on to all her kids. Dad can pass it on to his kids because all the mitochondria you have in your cells come from mom. That's one. 2, these conditions are classically associated with like visual problems. That's one. Usually it's like some kind of optic atrophy. And then another thing is they may describe muscle biopsy that shows ragged red fibers. If you see that buzzword, you really want to think about some kind of mitochondrial disorder. Now, the final thing here is just a quick aside on the Vactral association. It's just something you need to memorize. It's just a cluster of findings that tend to show up together in a kid, at least most or all of them. And the V stands for vertebral anomalies. Okay, the A stands for anal atresia. The C stands for cardiac defects, many different kinds of cardiac defects. The TE stands for TE fistula, right? Usually that shows up with an esophageal atresia. The R stands for renal defect, okay? And then the L stands for a limb defect, okay? So that's the Vactral association. Vertebral anomalies, anal atresia, cardiac defects, TE fistula, classically with an esophageal atresia, renal problems, and limb defects, okay? Now let's jump on to the next question. Okay, so Down syndrome, okay? So Down syndrome, there are many things I'm going to talk about here. You probably should not walk into any board exam without knowing as much as possible about Down syndrome, okay? So I'm going to talk about the genetic pathophysiology. I'll talk about the early onset neurological disorder they could have, the classic hematologic malignancy that shows up in Downs. We'll talk about some considerations before you begin sports. If a person has Down syndrome, we'll talk about the hand findings, we'll talk about the cardiac defects, we'll talk about the GI defects. Hopefully, as I'm reeling these out, you're really beginning to mull over the potential answers to these questions. We'll talk about the quartz screen findings from mom, from the amniotic fluid. We'll talk about the chromosomes found in a Robertsonian translocation carrier. Classically, those people don't have Down syndrome, and then we'll talk about the number of chromosomes found in a patient with Down syndrome from Robertsonian translocation. We'll talk about the pathophysiology behind that. Okay, so that's all I'm going to talk about. So now let's talk about it one by one. Okay, and after this, you'll feel like an expert on Down syndrome. Okay, so basically, how does Down syndrome arise? Down syndrome is trisomy 21. Okay, it arises through two mechanisms you probably want to worry about for exams. Okay, it could arise from maternal non-disjunction. I've talked about the different combinations for that, right? So where you don't have appropriate separation of homologous chromosomes in meiosis 1, or appropriate separation of sister chromatids in meiosis 2, or mitosis. Okay, and then another mechanism is the Robertsonian translocation. I'll talk about that in a bit. Okay, now the classic neurological disorder these people get is early onset Alzheimer's, right? So like Alzheimer's in their 40s, because they actually have 3 copies of chromosome 21. Okay, and remember that chromosome 21 encodes a gene product known as a presenilin 1, and presenilin 1 actually gives rise to certain subunits of the amyloid beta protein that classically accumulates in the brain in patients with Alzheimer's. Okay, now with regards to a hematologic malignancy, these kids tend to get ALL. Okay, remember ALL classically on exams shows up in kids that are less than 7 to 10 years old. Okay, remember that ALL is TDT positive, right? So terminal deoxynucleotide transferase. And one mnemonic, right, that you will learn from some review resources as you're studying for your board exams is all fall down. Okay, so all ALL fall down syndrome. Okay, so that's one easy way to remember that. Now, before kids with Down syndrome start sports, one thing you actually want to do is to get like a cervical/neck x-ray. Okay, because the thing is, many kids with Down syndrome have something known as atlantoaxial instability, and that can cause very serious, life-threatening, permanent spinal cord problems. Okay, so you want to make sure they don't have an atlantoaxial like subluxation or instability before you let them begin sports. Another classic patient population that tends to also have a similar warning, people that have had like long-standing rheumatoid arthritis. Before those people have surgery where you have to like manipulate their neck and all that stuff, you want to get like some kind of cervical neck x-ray, okay, to rule out atlantoaxial subluxation. Okay. Now, the classic hand finding in Hirschsprung, right? So like the single palmar crease, some facial findings. I guess I didn't put this on the slide, but some facial findings. They may have like the palpebral fissures, the epicanthal folds, the low set ears, the small head, right? So those just sort of things to keep in mind there. Okay, with regards to cardiac problems, they tend to have endocardial cushion defects, right? So like AV canal, your atrioventricular canal defects, okay? Because remember that those endocardial cushions are derived from neurocrest. And really, if you dug deeper and you spend time studying Down's syndrome, you'll see that most of the problems in Down's are just from neurocrest cell migration deficits, okay? So that's what explains the disparate findings, like the problems they have with endocardial cushions, the problems they have with Hirschsprung's disease. These are all neurocrest cell migration problems, okay? With regards to GI problems, right, so they could have Hirschsprung's, we've talked about that. They could have duodenal atresia, right? So if you see an abdominal x-ray on your step 1 exam where you see a double bubble sign, okay, the first part of the bubble is the stomach up until the pyloric sphincter, and then the second part of the bubble is the part of the duodenum that's proximal to the atretic duodenal segment, okay, that's your double bubble. If you see that, think of Down syndrome, think of duodenal atresia. And duodenal atresia, right, classically presents with bilious vomiting. Contrast that with pyloric stenosis, where you tend to have non-bilious vomiting, right? And pyloric stenosis usually shows up within the first 8 weeks of life on exams, right? And you remember, like the what is it called? Like it's like a mass you palpate, olive-shaped mass, peristaltic waves on abdominal exam in a young kid. That's usually like a firstborn male or was exposed to erythromycin for some kind of early life infection. Okay, those are all high yield risk factors. Okay, so that's one way to sort of differentiate pyloric stenosis from duodenal atresia. But duodenal atresia, Hirschsprung's disease, classic GI findings in Down syndrome. Okay, so let's talk about Robertsonian translocations, okay? Because they're very confusing, right? And since it's confusing, it's like very nice exam fodder. So in a Robertsonian translocation, the first thing that happens is it all starts with an acrocentric chromosome. So what does that big word mean, acrocentric chromosome? An acrocentric chromosome is basically a chromosome that is, I sort of think of it as a chromosome that is not equally divided, okay? So it has like one centromere, right? But there's like a very short arm of the chromosome that has very little genetic material, and then there's a long arm of the chromosome that has a ton of genetic material, okay? That's an acrocentric chromosome. So because things are not balanced, I sort of think of it as a seesaw that is not well balanced around the centromere. If that chromosome breaks at the centromere and the long arm goes off to its own place, the short arm goes off to its own place, and that long arm joins up with another chromosome, say like chromosome 14, for example, okay? You just had that process basically is what defines a Robertsonian translocation, okay? So you've basically destroyed one chromosome, but you've taken like all the high yield genetic information on the long arm and placed it on another chromosome, okay? So these people will basically have 45 chromosomes instead of the regular 46, because you've basically like trashed one chromosome, taken most of its material and just added it onto another chromosome, okay? So those people have 45 chromosomes. But in general, people that have that kind of Robertsonian translocation have no problems at all. Yes, they have 45 chromosomes, but they have a silent phenotype. And the reasoning behind that is they basically have 2 copies of all the genetic information that they need. Okay, so that is how a Robertsonian translocation works. Okay, and that's the case that will obtain in a carrier. A carrier will have 45 chromosomes. Now, how can bad things happen, right? So bad things can happen when you have something known as an unbalanced Robertsonian translocation, okay? And in an unbalanced Robertsonian translocation, a person can have Down syndrome from that. And those kids have 46 chromosomes, okay? 46 chromosomes. So how does that work? Well, the thing is, in the process of meiosis, right, the Robertsonian translocation carriers, right? So let's assume they trashed chromosome 21, took the long arm, put it on chromosome 14. In the process of meiosis, right, the carrier of the Robertsonian translocation can basically pass on the singular chromosome 14 that's tethered to the broken off long arm of chromosome 21. And the regular chromosome 21 that they have, because remember, everyone has normal 2 copies of chromosome 21. So let's assume in the gamete, right, like the sperm or the egg, they pass on the chromosome 14 that is tethered to the long arm of chromosome 21, and then they also pass on a regular chromosome 21. When that gamete meets with another gamete that has like one single chromosome 21 and they fuse to form a zygote, you basically form a fetus that has 3 copies of chromosome 21, right? So they have 1 copy from one gamete, the normal gamete. They have 1 copy from the abnormal gamete, and then they have the 3rd copy that is tethered to chromosome 14, okay? So they have a trisomy 21, so they can present with Down syndrome, okay? But with maternal non-disjunction in Down syndrome, right, instead of having 46 chromosomes, you have 47 chromosomes. You have like a legit extra chromosome 21, okay? So if you get an MBME exam question that describes Down syndrome findings and they're like, wait, this person has 46 chromosomes, you really want to think about an unbalanced Robertsonian translocation as the underlying pathophysiology. Very, very high yield to understand this whole Down syndrome business. So let's, and before we jump to the next slide, if you perform a quad screen on maternal amniotic fluid, in Down syndrome, you will have high levels of beta HCG and inhibin, okay? And then you have low alpha fetoprotein and estriol, okay? And one easy way to remember the things that are high is just remember the word high, H-I-G-H, right? H and I in high, okay? The H for HCG, the I for inhibin A, okay? Very easy mnemonic to remember that. Okay, so let's jump up to the next question. The next question says, what is your diagnosis? Just comparing and contrasting 2 disorders, okay? These are very easy points on an exam if you can recognize them, okay? So the first one is a prominent occiput, overlapping digits, clenched fists, and rocker bottom feet, okay? Hopefully you know these to be findings of Edwards syndrome, that's trisomy 18, okay? And then for the second one, it says rocker bottom feet, but the presentation here is cleft lip and palate and polydactyly, right? So like multiple digits. If you see this, think more about Patau syndrome, okay? Trisomy 13, okay? So remember, overlapping digits, clenched fists, prominent occiput, that's more Edwards syndrome, trisomy 18, okay? Smaller head, like microcephaly, rocker bottom feet, cleft lip palate, polydactyly, that's more trisomy 13 or Patau syndrome. Okay, so let's jump on to the next question. Now, a 5-year-old male with a long face, large ears, and large testicles. So with this, what's your diagnosis? What's the mechanism of inheritance? What's the genetic pathophysiology and the associated principle? What's the diagnostic testing? So how do you diagnose this? What's the common psych association? What's the common neuro association? Believe it or not, these are all concepts they love to test on the exam, right? So if you see a kid with big everything, right? So like long face, big ears, big testicles, hopefully you're thinking about Fragile X syndrome, okay? It's an X-linked disorder, right? So that's another reason it's higher, because most of the trinucleotide repeat disorders tend to be autosomal dominant inheritance, right? But this is different, okay? It's an X-linked trinucleotide repeat disorder, okay? So the trinucleotide repeats here are CGG repeats, okay? Remember that because it's a trinucleotide repeat disorder, it would demonstrate the principle of genetic anticipation, okay? Where the symptoms show up like earlier, they show up more severe as generations go by, okay? And in general, the way you diagnose this is you do molecular testing for the FMR1, okay? So like Fragile X mental retardation 1 gene, okay? And the psych associations here is just something you need to commit to memory. There's ADHD. ADHD is very common in kids with Fragile X, and autism is also very common in kids with Fragile X, okay? And then with regards to neurological problems, some of these kids actually have like very mild intellectual disability, but they're usually like normalish with regards to IQ. I mean, it's not like profoundly low. It's not good, but it's okay. Okay, it's okay. And they also tend to get a lot of seizures. Okay. In fact, Fragile X syndrome is actually the most common cause of inherited intellectual disability in the U.S. Okay, so just something to keep in mind. Okay. So let's jump to the next question. This one is a very easy one. This is an auto-click question on the exam. Okay. So tall male with gynecomastia, infertility, no facial hair, and I'll just tell you that he has a very tiny testicles. Okay. Hopefully you know this to be Klinefelter syndrome. Okay. And the karyotype is 47XXY. Okay. Very easy to recognize that on tests. Okay. So next question. So this one is loaded because it's very high yield. Okay, so this question describes a female with a low posterior hairline. Okay, a webbed neck. Okay, congenital lymphedema. Okay, I'll just tell you that another buzzword, although they could try to trick you by putting congenital lymphedema like I did, but another word you could see is cystic hygroma. Okay, and short stature. Okay, so what's your diagnosis? I really hope you're telling me that this patient has Turner syndrome, okay, and the karyotype, right, obviously is 45X, okay, it's 45X. Patients may actually have less severe symptoms if they have like a genetic mosaicism across their different cells all over the body. The cardiac associations for Turner syndrome, you want to remember your aortic problems primarily, okay? So remember your B's and your C's. Your B stands for a bicuspid aortic valve, right? So these kids may have like aortic stenosis like early, like in their 50s, for example. Contrast that with like the regular people that get aortic stenosis from valve calcification in their 70s or 80s, okay? The C stands for coarctation of the aorta, okay? So if they describe a patient that has hypertension in the arms but hypotension in the legs, think about coarctation of the aorta, okay? With regards to kidney problems, right? So classic exam association here is horseshoe kidney, okay? Basically like the inferior poles of the kidney fuse, okay? And then they're stuck under the inferior mesenteric artery, okay? Very common condition in patients with Turner syndrome. And in general, if you want to correct the short stature, you can actually just go ahead and administer growth hormone while the kids are small, okay? It can actually help them sort of catch up some of their lost height. Alternatively, for the, I guess not alternatively, but if you wanted them to have a secondary sexual characteristics at puberty, you can actually go ahead and give them estrogen, and that should help them at least get like some maturation of the breasts and stuff like that. And then Turner syndrome, think of it as being a kind of hypergonadotropic hypogonadism, and the reason it's a hypergonadotropic hypogonadism is based on the fact that these kids tend to have strict ovaries, okay? So the ovaries are not producing anything, okay? So there's no negative feedback at the level of the hypothalamus or the anterior pituitary. So these kids tend to have very high levels of FSH and LH, okay? That's why it's a hypergonadotropic hypogonadism, right? So Turner syndrome is actually a very high yield cause of primary amenorrhea, right? So failure to menstruate. Now, the close cousin to Turner syndrome is something known as Noonan syndrome. So this is lower yield compared with Turner's, but it's one of those things where most people will probably get it wrong on an exam, okay? But hopefully you won't be one of them because you listened to this podcast and actually paid attention, okay? So the close cousin is Noonan syndrome, and Noonan syndrome actually has many commonalities with Turner's, right? So you have like the cystic hygroma, you have the web neck, you have many of the same findings as Turner syndrome, okay? But there are some key differences you want to recognize, okay? Turner syndrome is primarily a problem in girls, okay? Noonan syndrome classically shows up in boys, okay? So if you see a Turner syndrome presentation in boys on your exam, you want to think really hard about Noonan syndrome. Although Noonan syndrome also shows up in girls because it actually has autosomal dominant inheritance, okay? So it shows up in both boys and girls, but on exams, classically, it will show up in a boy, okay? That's one. Another thing is the gene mutation is the PTPN1 gene mutation. That's very low yield. I don't really envisage that being tested, but who knows, okay? But one very subtle difference that would really help you differentiate this Noonan from Turner syndrome on the exam is that in Turner syndrome, the kids tend to have a left ventricular outflow tract problem, right? So like coarctation of the aorta, bicuspid aortic valve. But in Noonan syndrome, the kids tend to have more of a right ventricular outflow tract problem, right? So LVOT problems in Turner syndrome, RVOT problems in Noonan syndrome, okay? Like pulmonic stenosis, for example, okay? So think more of left-sided heart problems with Turner's, right-sided heart problems with Noonan's, okay? Now, so I'll say that's probably all I want to discuss. Let me see if I'm missing out on any points here. Yep, that's all I want to discuss here. Okay, so let's jump up to the last question. Okay, so the last question is just a grab bag. So catch-22 syndrome, the two mechanisms behind the development of Prader-Willi syndrome, the two mechanisms behind the development of Engelmann syndrome, and then the classic presentation of both disorders, and then the charge association. Okay, so let's just round out with this. Now, the catch-22 syndrome, right? So hopefully you already know this to be the George syndrome. Okay, remember that the pathophysiology is failure of the third and fourth pharyngeal pouches to develop properly. Remember, those pharyngeal pouches are derived from endoderm, not ectoderm, endoderm. Okay, it's a relatively common disorder. In fact, it's probably the second most common genetic diagnosis if you're comparing with Down syndrome. Okay, and the catch-22, what does it stand for? Okay, these kids tend to have like a cyanotic congenital heart diseases like a truncus arteriosus or tetralogy of Fallot. They also tend to have craniofacial anomalies, right? So that's what the A stands for, right? So like they could have like a very small mandible, a small mouth like macrognathia. They may have like low set ears. The T stands for thymic hypoplasia, right? So these kids tend to have a lot of viral and fungal infections because they essentially have a T cell deficit. Remember that your thymus is where your T cells go to mature. Okay, so they may give you an exam question, and in the Q stem they may say there is no thymic shadow on a newborn chest X-ray. Okay, remember that severe combined immunodeficiency from an adenosine deaminase deficiency will also present in a similar fashion, the absence of a thymic shadow on a newborn chest X-ray. And then the C stands for cognitive problems, right? So these kids tend to have an intellectual disability. The H stands for hypoparathyroidism. Okay, remember your parathyroid glands and your thymus come from the third and fourth pharyngeal pouches. Okay, so these kids could actually, a very classic exam question is a kid presenting with hypocalcemic seizures, okay, and a prolonged QT interval on a newborn EKG. Okay, think about the hypocalcemia from the hypoparathyroidism that accompanies the George syndrome. Okay, and then the 22 stands for the deletion, the 22q11 deletion on chromosome. So the deletion on chromosome 22. Okay, the George syndrome is a catch-22 syndrome. Another syndrome that's lower yield but may show up on your exam, okay, that also has many of those catch-22 features is something known as a velocardiofacial syndrome. Okay, velocardiofacial syndrome. Okay. So, Prader-Willi versus Angelman, okay? So, the thing is, chromosome 15, in general, for guys, okay, you genetically silence, right? So, this is genetic imprinting coming into play. You genetically silence mom's chromosomes and express only dad's chromosomes, okay? For ladies, you genetically silence dad's chromosomes, okay? Again, that's genetic imprinting, and you express mom's chromosomes, okay? So with that understanding of how genetic imprinting works with chromosome 15, let's talk about how Prader-Willi syndrome arises, shall we? Okay, so there are two ways a person can get Prader-Willi syndrome. Again, I said if you're a guy, you genetically imprint mom's chromosomes and express dad's chromosomes. But let's assume you have a deletion of dad's chromosome 15, okay? Then you can certainly have Prader-Willi syndrome. Alternatively, if you inherit both chromosome 15s from mom, right? That's the principle known as uniparental disomy, right? So uniparental, one parent, disomy, two chromosomes, okay? That means that you shut off both of mom's chromosomes. You have no dad's chromosomes to express in the first place. And again, you also have a very similar phenotype to a person that has a deletion of dad's chromosome 15. Okay, and for Angelman syndrome, right? Again, I said that normally in women, you shut off dad's chromosome 15 and express mom's chromosome 15, okay? So let's assume you have some problem where you have a deletion of mom's chromosome 15, right? You won't have any genetic expression of those nice genes on chromosome 15, so you have Angelman syndrome. Alternatively, let's assume you inherit both chromosome 15s from dad, okay? Again, uniparental disomy, okay? You could also have Angelman syndrome with that, okay? And the classic presentation of Prader-Willi syndrome on exams is a kid that is a guy, okay? So P for pop, okay? So it's a guy, okay, with short stature, okay? The guy is usually super obese, like a high BMI, okay? They tend to have super small testicles and penises, I guess, if you're going plural there. And then they tend to eat a lot, okay? In fact, for some of these kids, you actually have to like lock up the fridge. If not, they will get into a lot of problems. They just keep eating, okay? So just something to keep in mind. For Angelman syndrome, right, they classically describe a kid with ataxia. Again, it's a lady this time, okay? So remember the M in Angelman for the M in mom, okay? And those kids tend to have like a very small face, okay? And they laugh a lot, okay? So like they have just uncontrollable laughter, okay? That's a very high yield association for Angelman syndrome, okay? And then the charge association is just like Vactrel that I mentioned earlier. It's just another association you need to probably commit to memory. The C stands for coloboma, okay? I would encourage you to look at pictures of this. It's like a keyhole defect in the iris. The H stands for heart disease, okay? So like congenital heart problems. The A stands for atresia of the choanae, okay? So like choanal atresia, right? So the classic presentation of choanal atresia on exams is a kid that is cyanotic, right? So they're like blue, but once they start crying, they become pink, okay? Basically, they have occlusion of the inner parts of their nose, so they can't breathe in through their nose, so they become hypoxic. But when they cry, they open up their mouths and they can breathe that way. Okay, now the R stands for retardation, right? So like mental retardation, we tend to not use that term anymore. We now use the term intellectual disability. And then the G stands for GU anomalies, okay? So like genitourinary problems. And then the E stands for ear anomalies, okay? So that's the charge association. The charge association, actually there's some literature that has been coming out recently that shows that a fairly sizable number of kids that have this association, like more than 50% of them, have a CHD7 gene mutation on chromosome 8, okay? A CHD7 gene mutation on chromosome 8. So that's just something you'd want to keep in mind, okay? So that's the last part of this presentation. Although I guess one thing I'll just add for Prader-Willi syndrome is those kids actually tend to be floppy at birth, okay? So they're like hypotonic. So just another thing to keep in mind, okay? So with that, I'm gonna end this podcast. I would encourage you, like I promise you, you'll probably get a couple of questions right from this podcast on many exams, because these things, they have like this wow factor associated with them, so they love to test them pretty frequently. As long as you can recognize the clinical presentation, know some quick genetics, understand some mechanisms, especially with like Down syndrome and the Angelman / Prader-Willi syndromes, you should be good to go. Okay, so I wish you all the best. If you spot any errors or have any questions, just make a comment, send me an email at divineinterventionpodcasts@gmail.com. and I'll be sure to get back to you as quickly as I can. Okay, have a wonderful day and stay blessed. Shalom.